So this session's on heart failure, another big topic to cover in a short period of time. Why is it important? Well, it's a significant cause of morbidity and mortality in our communities, and it costs us, our total health budget, a lot of money. Up to 2% of our health budget is spent on heart failure. We also know that this disease, again, falls unequally on our Māori and Pacific communities, so up to 2.5% in Māori and Pacific. It is a disease of getting older. New Zealanders are living longer, a good thing, but New Zealanders are living longer with chronic disease, and this is a clinical presentation of a chronic disease. What we also see is that Māori and Pacific are much more likely to be admitted, usually on average 10 years younger than Pākehā with heart failure, and much more likely to be admitted below the age of 75. As you can see, there's very few Māori and Pacific admitted with heart failure over the age of 75. Why is that? They're not living. They're not living. We also know, and I think those of us that see and treat people with heart failure and other conditions, is that they frequently have other conditions. This is a common bedfellow with lots of other chronic illnesses, be it chronic renal disease, be it chronic obstructive pulmonary disease, osteoarthritis. We talked about the complexity of managing someone whose predominant symptom may relate to osteoarthritis or rheumatoid arthritis, and our concerns about what we would like to do, but also we've got to remember what's important to the patient and engage the patient with a way forward. If we look at some overseas data, and we don't have a lot of data currently in New Zealand, but this is some overseas data from the UK, published in the British Medical Journal earlier this year. The improvements in outcomes have been modest over the last decade. And what we also see is that there is socioeconomic inequality. So if you happen to be well off in the UK, you do better if you've got a diagnosis of heart failure than if you are less well off in the UK. But if you look here, modest improvement in survival over the last 10 years. Should it surprise us? Probably shouldn't really, because the treatment options that you and I have had to treat people with heart failure have not changed dramatically in the last 10 years. Our evidence base dates back to 1987, when we first started seeing the ACE inhibitor trials coming through in a heart failure population. We had data previously in a post-MI population, beta blocker trials in the 1990s. The most recent trial that we had was the emphasis trial with eplerenone in 2011 that has informed the previous iterations of guidelines. I think this is an important slide, and it's from that same UK paper, the cohort study. It tells us that if we pick up people early in their heart failure journey, they do better. So we can pick up people before they're hospitalized with heart failure, they do better. And it should emphasize to us the importance of trying to pick up people pre-acute decompensated heart failure who may have symptoms of heart failure. And I think we're all familiar with the NYHA symptomatic classification, class 1's no symptoms through to class 4 symptoms at rest. You may not be as familiar with this classification that's used by the American Heart, the American College, ACC, and more recently the European societies. It's looking at the development of heart failure through stage A, where people may have structural abnormalities that may lead on to left ventricular dysfunction, be it systolic or diastolic or valvular disease, that leads on then to symptomatic heart failure, that leads on to refractory heart failure. So the importance of this is to emphasize that We've got patients who are at risk of developing heart failure with the conventional risk factors that all of us see and manage, through asymptomatic LV dysfunction to end-stage heart failure. It's designed to emphasize that this journey is not necessarily, it doesn't have to happen, that they emphasize the preventability of heart failure and designed to recognize the progressive nature of left ventricular function, so diastolic, systolic through end-stage heart failure. So here's a case. This is a 54-year-old lady, and we'll go through this case reasonably quickly because Bruce, this is around primary prevention, but this is a lady that's got important risk factors for cardiovascular disease. Her 5-year risk is over 15% using the current equation, and that's the paper that Bruce was alluding to earlier on. I think there's over 400,000 people in, 400,000 people in the recent PREDICT paper. And there's new variables, as we mentioned. Atrial fibrillation, ethnicity, deprivation status is included as variables in the new calculator, and I'm pleased that BPAC have it available because it's taken a wee while to get there. Yeah. Is it integrate nicely with the PMS?
We're on meeting in advance.
Yeah, okay. Yeah. I'm told it's meant to integrate with indice as well, once indice. Any practices in indice yet? No?
We have some
Yeah. So, appropriate advice. This predates the, so a bit of torvastatin, antihypertensive, single agent, Bruce again, we need to do better. I need to listen to myself. But again, I'm not going to go through those. Bruce mentioned all of these earlier, but just to emphasize that we believe targets are important in high-risk populations. To me, and this argument, I don't know your thoughts on this argument, I've had this argument at PHO meetings, well, why should we be treating to target? To me, it's nonsensical. If you've got a high-risk patient and you're actively managing that patient, why are target blood pressures and LDL not relevant, and why should you not want to report those?
Well, I think they would have been negotiating with the patient, wouldn't you? And I guess if they know that how high risk, because I think people don't really have a clue how, because they feel healthy and they're asymptomatic, they think they're not at high risk. But you've got to know what their variables are. Yeah.
Yep. And they're the blood pressure ones that Bruce mentioned earlier as well. So again, the reason I show that case in a heart failure talk is this is a patient who's stage A. Okay, so we've got the opportunity to potentially prevent that person developing symptomatic heart failure, be it 5, 10 years down the line. So important to emphasize that we're not just doing it for the sake of doing it, it's to prevent subsequent cardiovascular events. So this is someone that's got heart failure. So this is a man, someone from a few years ago now, late presentation anterior MI, didn't receive any form of reperfusion therapy. And 1 in 3 New Zealanders still do not receive reperfusion therapy following an ST segment elevation MI presentation. If you do not receive reperfusion therapy, as you would predict, you do worse than if you receive reperfusion therapy. And there's variable reasons why people do not receive reperfusion therapy, including late presentation. One of the things that we've been successful with the Heart Foundation in doing is the heart attack awareness campaign, and we've seen when that is pulsed, and we're now starting to try to pulse that through the year, is that we see more people presenting with chest pain, which is a good thing. We want to see people presenting with chest discomfort. But he had a cath 4 days after his presentation. He had an LAD that was opened up. His ejection fraction was 40% pre-discharge. So he's coming to see you 2 years post that event, and that's the medications that he's on. He's on metoprolol 23.75. He's on a small dose of cilazapril. He's on aspirin. He's on a homeopathic dose of atorvastatin. And examination, few crackles. He's a little bit tachycardic and a little bit hypertensive. So we'll give you some investigations. His ECG shows his old anterior infarct. his natriuretic peptide is elevated, but by providing the natriuretic peptide, that allows us to stratify early access for echo. So he gets an echo done reasonably quickly. His ejection fraction is 32%. So what now? What are you going to do now? And I've shared the slides, so you've got the slides to have a look at later. Treat the target? Treat what to target? Okay. Okay. So do you think he's got heart failure? So he's got heart failure, yeah? So why do you think he's got heart failure? It's interesting I've not given you a chest x-ray. Chest x-ray, we could have given you a chest x-ray. But we tend to go for these things today, don't we, more often? So his natriuretic peptide's up, isn't it? A natriuretic peptide, and that's not up a little bit, that's up significantly. So 652 is a high natriuretic peptide. So that's consistent with the diagnosis of.
I was going to say, the thing with chest x-rays, a negative chest x-ray in somebody with heart failure is likely to be a false negative. You can actually show that mathematically. If it's a positive one, you're fine, but when it's a negative, in fact, I have a whole lecture I give the medical students based on a patient I missed with heart failure because they had a normal chest x-ray, and I thought this was pre-BMP.
Yeah, and some of the, as you know, Bruce, some of the older guidelines would say if you're seeing someone who you think has got symptoms consistent with heart failure, and they've got an abnormal ECG or an abnormal chest x-ray or an elevated natriuretic peptide, then they are likely to have heart failure. So the abnormal ECG would actually fit in with that as well. But I think we go straight more often than not today for a natriuretic peptide. I mean, I would rarely do a chest x-ray on someone who's coming to the clinic. People will still get them acutely, but someone coming to the clinic, we would normally just do a natriuretic peptide or ask for a natriuretic peptide.
Well, they're now saying the very high ones is probable heart failure, don't they? They now say if it's over 250 or 300, they say it's probable.
Yeah.
Whereas they wouldn't, they never used to say that before.
Yep. So what we do, and where the natriuretic just to digress slightly about natriuretic peptides, complex with age, and we know there are variable things that will influence natriuretic peptides also. So as we get older, they go up. So there's age reference ranges that are available, I think, certainly on most of the stuff that I see published in the Midland region. When you do a natriuretic peptide, you get the age reference bands to see how your result fits with the age of the patient. But also we know high blood pressure, anything that causes left ventricular hypertrophy, cor pulmonale, atrial fibrillation, renal failure, they can put up natriuretic peptides as well. What can put them down? Diuretics can put them down, and that's a really important one to remember. So you may be seeing someone that's already had lots of diuretics. You do a BMP and it's 30. You don't know what to make of it. So you may want to stop the diuretic before you look at what else to do if you're concerned the patient does not have heart failure. Anything else? Yeah, obesity. Obesity is a really good one important one to remember because certainly in our region, Therapy, a lot of the people that we see are big people, and a lot of them have heart failure, and their natriuretic peptides are often not elevated. Don't fully know why obesity puts it down, but often it will be reduced or not elevated in someone who's got heart failure who is markedly overweight. So what are we going to do? So I'll remind you of the medication. Well, that's our goal really, isn't it? So in someone you or I see with heart failure, well, I'm not certain that's the right order I would put this in. I've taken this from somebody else's slide. I think the first thing is to make your patient feel better. Okay, so we've got to address the patient's symptoms, to engage the patient in what's next. So if you or I make someone feel better, they're much more likely to listen to you when you're talking about other medications that may not make them feel better, but in the longer term reduce their mortality. We want to keep people out of hospital, and we want to try and prevent progression of myocardial or valvular disease where appropriate. So we know that this is guideline medicine. This has been around for a long time. So class 2 to 4, so our patients class 2 symptomatology. So an ACE inhibitor is recommended in addition to a beta blocker for symptomatic patients. 1A, lots of trials telling us this is the right thing to do. A beta blocker in addition to an ACE, symptomatic stable patients to reduce hospitalization and death. So both to reduce hospitalization and death. Lots of trials telling us these are of benefit to our patients who present with heart failure, reduced ejection fraction. So I'm talking about heart failure, reduced ejection fraction, not heart failure, preserved ejection fraction. If time permits, we'll talk a little bit about that at the end. So a common question, does dose matter? Does dose matter? I think dose does matter. We've always tried to get people up to maximal doses of both an ACE inhibitor and a beta blocker. This is some data, registry data from Europe, looking at patients with heart failure, reduced ejection fraction. Bottom line is that if you did not reach more than 50% of recommended doses, there was an increased morbidity and mortality for patients. So how do you and I interpret that into clinical practice? So you've got 2 drugs you might want to start on someone you're seeing with heart failure, reduced ejection fraction. I would interpret this to help me. I would get the dose of my ACE inhibitor to at least half the recommended dose, then look at the introduction of a beta blocker to get my beta blocker to half the recommended dose. And if I've got blood pressure and renal function that allows, I would then look at up titrating the ACE inhibitor probably next, or the beta blocker if they're still tachycardic. Make sense? Make sense? Again, do elderly people benefit? And we hear this lots of times, lots of different medications. Do elderly people benefit from statins? Do they benefit from ACE inhibitors? Well, there's no data to tell us they don't benefit from ACE inhibition, and this is the Sweetheart Registry, which suggests that they do benefit as well as younger patients with all-cause mortality and all-cause mortality and hospitalizations with heart failure. And that, to me, is probably a much more meaningful outcome for elderly patients with heart failure. You want to keep your elderly person with heart failure living well in the community. That's what they want.
Interesting, NNT is lower for the older people as it will be for blood pressure. NNTs are very small when you get up to old people, so and they're very large for young people. So forget your emotions, treat on evidence.
Again, ARBs or ACE inhibitors, they're probably as good, they're no better. But you can feel, you'll be confident if you have to change for side effects, and the commonest side effect that we see is cough, then we've got data to support saying they are as good as an ACE inhibitor. So back to our man, and he's come to see you 2 years post his index event, his MI, with NYHA class 2 symptoms of effort intolerance. There are his medications. So what are you going to do? Increase the ACE, increase the metoprolol, probably increase the atorvastatin. Yeah. So again, the last point, trying to prevent disease progression that may cause more problems. This is important, so let's not forget about this. Rule of thumb, a 1 millimole reduction in total cholesterol translates into a 20% reduction in events. So it's powerful medicine bringing down cholesterol. So what we did with this man, of course the other thing, he's not on a diuretic. So we've got to make him feel better. So a diuretic will make him feel better. It will relieve pulmonary congestion, hopefully lower the BNP, make him feel better. We talked about earlier, there is no data around the prognostic benefit of loop diuretics specifically, but there's been background therapy in all of these trials. I don't think that trial will ever be done, to be honest. Okay, so that's what we did with this chap. Slowly up-titrated his medications, added furosemide to make him feel better, give him a little bit more atorvastatin, probably not enough, And because he has left ventricular systolic dysfunction, ejection fraction below 35%, and it's an ischemic etiology, he had an ICD put in his primary prophylaxis, which we'd forgotten about previously. So 6 months later, he comes to see you. You've been actually very good at being able to up-titrate things. You've got him on pretty good doses of metoprolol, cilazapril. He's on 80 milligrams of furosemide now for his symptoms. He's on 80 milligrams of atorvastatin and aspirin. So what are you going to do now? Nareesh, what are you going to do?
Somewhere in there you've got to get him weighing every day and trying to reduce the sodium and those things too. Now you've got those ARNIs.
Have we still got some blood pressure to favour?
Yep. I don't know what my next slide is, so I'm not going to show you my next slide just yet. So what are you going to do? What would the guidelines tell us what to do next? What? Spironolactone, yeah? So that's the next cab off the rank for us, isn't it? And again, we've got a couple of trials to tell us that if you add a mineralocorticoid antagonist and heart failure reduced ejection fraction, and people who remain symptomatic despite treatment with an ACE and a beta blocker, there is benefit at reducing hospitalization and mortality. Hospitalization and mortality. So keeping them well in the community and also a mortality benefit. And again, if you look at the combination, some data we have would suggest that if you use the combination together, over 3 years, we may reduce mortality alone by about 60%. Spironolactone, we talked about it earlier, the complexity of using spironolactone. I think it is a difficult drug to use, and I know when we first started using it, post the index trial, the Rails trial many years ago, we got ahead of ourselves and we were starting spironolactone in people who were not symptomatic, but whose LV function was not quite normal, and we ran into all sorts of problems. We ended up having some people admitted with acute renal failure, often in the setting of a concomitant other illness, such as a GI illness. So it's the one drug that I tend to empower patients to stop themselves before seeing you. I say if you get a GI illness, lots of diarrhea, lots of vomiting, stop this drug, make an appointment to see Bruce. Keep the other drugs going, but stop this one until you see Bruce. We also are fortunate we've now got eplerenone available, because not everybody can take spironolactone, and the biggest issue with spironolactone, of course, is it can cause gynecomastia in men. We often forget to tell male patients that this is a potential side effect. And I think that's wrong. I think we need to explain the side effects again to engage and earn trust of our patients. If they get gynecomastia, we now have another option available too, is the eplerenone. Easy drug to use, easy drug to remember. The dosing's the same as spironolactone, 25 milligrams a day. You have to apply for special authority. We can all do that, so it doesn't need to be me. You can do that as well, as long as it fulfills the criteria. Anybody got any experience with eplerenone? Yep. It's easy to use, isn't it? So again, just think about getting back to Goodfellow and what you might do Monday. You may have patients you look after with heart failure, reduced ejection fraction, who you're struggling a bit with. They may have tried spironolactone, it's been stopped because of the fact that they got gynecomastia. Eplerenone may be an option for that patient population. Okay, so maybe there's a way to look at your records to see is there people who may benefit from this. So anyway, 6 months later, he's still not quite right. He got better for a wee while, he's gone backwards again. He's on a reasonably hefty dose of Spiro, 50 milligrams a day, still on a big dose of furosemide. His natriuretic peptides come down a bit, his LVs looks a bit worse. What are you going to do? What are you going to do? So we know, and this is data from the PARADIGM trial, a trial looking at a new treatment, that intensification of diuretic therapy in someone you've got has been stable for a while and you're having to increase his diuretic because he's coming to see you because he's symptomatic, that is not a good thing. That's akin to an admission with acute decompensated heart failure. And we know if you're admitted acutely, your prognosis is not as good as if you're in the community from the stuff that we showed you earlier as well, or an emergency department visit. What about digoxin? Would anybody consider digoxin here? No? Digoxin's not unreasonable to consider. Digoxin's been around for a long time, and we thought previously there may have been a mortality benefit from it, but the data that we have today would suggest there's no mortality benefit to it. It makes people feel better, and people who you've established on digoxin who are feeling better, if you discontinue digoxin, they're often decompensate with a worse prognosis. So if you've got people on dig and you've used it, they feel better, I'd probably keep it going. I wouldn't look at stopping digoxin. But our guidelines have moved on. Our guidelines, and this is the Australian, our own Cardiac Society guidelines, it's not the Australian and New Zealand Cardiac Society guidelines, would suggest that we now have, so someone's ACE inhibitor, beta blocker, mineralocorticoid antagonist, people remain symptomatic, LV function remains poor, that we look at changing to this new class of medication called an ARNI. So what this class of medication does, it blocks two things. It inhibits neprilysin and blocks the angiotensin receptor system over here, the RAS system over here as well. And by doing that, what it does is we get rid of all the bad things over here of overactivation of the RAS via valsartan. We know that's been around for a while. We know that's a good thing to do. Vasoconstriction we're blocking. And we potentiate the benefits of vasodilatation that the neprilysin bit acts on, and you get a natriuresis and vasodilatation. That's all very well. There's been a number of animal trials done, a number of small first-in-man trials done. But this is the pivotal trial on which this drug has been approved for use around the world and has been available for the last 12 months to us in New Zealand. This is the PARADIGM trial. So in PARADIGM, there were over 8,000 patients randomized to Entresto, sacubitril valsartan combination versus enalapril. Why enalapril? Enalapril is the most studied drug in heart failure reduced ejection fraction. So they didn't choose placebo, they chose an established heart failure reduced ejection fraction medication. A sick group of patients with a mean ejection fraction of 30%, 70% class 2, 60% in ischemic etiology. The trial was stopped early due to a reduced cardiovascular death in patients who received Entresto versus enalapril, 20% relative risk reduction. The primary endpoint was met. So again, primary endpoint, death or first heart failure hospitalization, so a combined primary endpoint, 20% relative risk reduction, 5% absolute risk reduction, and that's huge in cardiovascular medicine to have that degree of absolute risk reduction. And Bruce, you're going to tell me the number needed to treat without me
20,
showing.
around just
There you go.
20, yeah.
Yeah. And
It's
that's over.
It's 100 divided by 4.7, so it's not rocket science.
Yeah.
It's inverted.
So that's over just over 2 years. So that's huge. I'm not going to take you through lots of other data with this trial, but it reduced lots of the secondary endpoints. Heart failure hospitalization reduced by 20%, all-cause mortality. Patients felt better. Also, it was well tolerated. Patients were less likely to develop cough, hyperkalemia, or worsening renal function, less likely to discontinue Entresto due to an adverse event, more troublesome hypotension, but it did not lead to more discontinuations of therapy. So it's available in New Zealand. It's been available since October last year. And that's the criteria which effectively mirrors the entry criteria for the trial I've just shown to you. So symptomatic heart failure, reduced ejection fraction on optimally tolerated doses of conventional therapy who remain symptomatic. Really, this is really important. And we've had a couple of scares up in Terafity where people have been prescribed Entresto by us. They've gone up the coast again. There's been delays in communication and someone's restarted an ACE inhibitor. Potentially very, very dangerous because the incidence of angioedema increases quite significantly with that combination. So it cannot be co-administered with an ACE inhibitor. So if you're seeing someone that you're looking to change to Entresto who's on an ACE inhibitor, they need at least a 36-hour washout period before you commence the Entresto. And that's just saying what I've said. So starting doses for most patients after that 36-hour washout period, it's an unusual dosing regime of the two ingredients, but it's 1 tablet twice a day, aiming to up titrate to the 97-103, 1 tablet twice a day. Takes us back to the old days with ACE inhibitors, doesn't it? That we're doing this slowly, we're wary of hypotension. Take your time. Get your patients up to the optimal dose if possible. If you've got concerns, there's a lower dose, so half of this dose roughly. We can look at 24, 26, and again, plan to step up slowly but surely. That's for patients who you've got concerns about symptomatic hypotension, elderly, severe renal dysfunction as shown there. So our patient, Cilazapril was stopped, commenced Entresto, up titrated to that dose. In July 2019, he's on maximal dose. We've been able to back off spironolactone to 25 milligrams a day and also reduce the dose of furosemide. Symptomatically, he's improved and his natriuretic peptides improved as well. So experience with Entresto, ladies?
Yeah,
Good?
people really feel better on it.
Any primary care practitioners, patients on Entresto? Have you started it? Yep, but you've started?
Yes.
Yeah, good. Yeah, experience is good? Yep. Bruce, have you any people on it? So our experience, I'll just share our experience briefly. So we've been pretty active for a DHB our size. We've got 40 people on Entresto since October. Majority, as one would predict in our community, are Māori. Age range 38 to 84. All who have tolerated it, the vast majority of people tolerated it. So 2 people out of 40 did not tolerate it. But the vast majority of people who tolerated it felt much, much better. We had 1 death. People with heart failure die. You know, we are going to see people with heart failure die no matter what we do. So 1 out of 40 during this period is actually quite low, I would suggest. We've not followed everybody up with echo. We followed a few up with echo. And we've seen improvement in LV function in 4 or 5 patients thus far of maximally tolerated doses. We strive very hard to get the dose up to the maximally tolerated dose, and we keep bringing people back or liaising with primary care to see if we can get people up to the maximally tolerated doses. So I actually think this is a game changer for heart failure reduced ejection fraction in New Zealand. And I think we just need to have confidence in how we use this drug. It is a well-tolerated drug in our experience, and we should not be denying people who remain symptomatic with heart failure reduced ejection fraction the benefits of this agent.
Do you aim, I mean, it's interesting that his furosemide dose was down quite a bit. Do you try and get people down and off? That's always been my aim, yeah. Yeah, just 'cause it's a miserable drug to take, isn't it?
So I agree, and I think furosemide is good for symptoms, but it often makes it complex for us to optimize on the medication. So I think we should try and reduce it as best we can.
Are you going to publish this? You should send a letter to NZNJ or something.
Yeah, we're just trying to get the data all collated. So we've got some data. We've got some data around the safety of initiating sacubital valsartan during first presentation with acute decompensated heart failure. What this trial looked at was not outcomes, but changes in BNP, and they showed a significant reduction sooner in people that got BNP with sacubital valsartan. But what they also showed that it was safe. Okay, so that's relevant to your question, Joe. Is it safe? And it appears safe. What they also showed, which was not powered for this, an exploratory clinical endpoint, a 40% reduction in readmission with early commencement of sacubital valsartan as opposed to an ACE inhibitor. They're just the markers again. They measured other things in addition to BNP, and they also all came down in people that received early initiation. So I think if you speak to people that have had access to this a little bit longer than we have, and do not have restricted criteria around who they use it on, they're doing exactly what you say. So the Glasgow unit, active heart failure unit, people come through the front door, they get this drug first cab off the rank, they do not get an ACE inhibitor. And I think we're going to see that sooner. So some practice tips, and I think it's important in forums such as this that we do talk about some practical things, and I think these are things that we all evolve as clinicians. Our goal should be to try to optimize these medications as best we can, acknowledging what we said earlier. Let's aim, for example, cilazapril 2.5, bisoprolol 5 as a minimum in the patients that we've got on an ACE inhibitor and a beta blocker. So double our doses up fortnightly, maybe even 4 weekly if you have to, but try to get your doses up. Don't maximize one drug. I believe we don't know the answer from clinical trials because we don't know what you do. Do you start a beta blocker first? Do you start an ACE inhibitor first? I mean, conventional wisdom would be, because a lot of the ACE inhibitor trials were in people with congested heart failure, whatever that means, get them on that first and then start a beta blocker. Just to again emphasize what we talked about diuretics, Bruce. Great for treating symptoms, but if you can't optimize these drugs, think about reducing the dose of your diuretic. We forget this step a lot, I think. We do not monitor after up-titration. I think it's really important that we know what the renal function is, what the heart rate is for optimizing beta blockers, and whether patients develop symptomatic postural hypotension. So some troubleshooting. So symptomatic hypotension, again, is the patient dehydrated? Have we over-diuresed patients? Think about other drugs, so ones that are not relevant to ongoing management of that patient's heart failure. Do they still need amlodipine for hypertension? Can we get rid of nitrates in someone that's got angina but hasn't had symptoms of angina for 2 years? Think about what we can do. We may need to consider reducing the doses of our medications of prognostic benefit. Highlight that. It's symptomatic hypotension, yeah? I'm very comfortable with someone with heart failure walking around with a systolic blood pressure of 90 millimeters mercury as long as they're not symptomatic and we've got them on good doses of medications of benefit to keep them well in the community. Renal function, and I think this is a really important slide. We talked about it earlier. You mentioned it earlier, Bruce, around management of hypertension. We should expect we're going to knock renal function around a little bit in people with heart failure, reduced ejection fraction, when we crank up our care. As long as EGFR does not decrease by more than 30%, that's okay, that's acceptable. But if it's more than 30%, you've got to be a little bit concerned. So you're in that's a complex patient. That's usually not a good sign if we are compromising renal function to that degree in someone with heart failure. It's a really difficult scenario and complex patient to manage. So again, look at other medications. Is the patient on a non-steroidal? Other supplements? We may need to decrease our medications, and we may need to phone a friend. And I frequently will speak to renal physicians about these patients as well. but that's acceptable, yeah? Less than 30% is acceptable. Symptomatic bradycardia. Well, okay, well, if you send me someone who's saying he's got symptomatic bradycardia, the first thing I'm going to ask, well, where's the ECG? So we need an ECG, not just you think someone's got symptomatic bradycardia. So please confirm with an ECG. Look at other drugs, look at digoxin, for example, in that setting. They may be on that horrible drug, amiodarone. We may need to reduce the dose of the beta blocker. And of course, don't forget, people do decompensate in the community. We want to try and prevent them coming into hospital, so we may need to look at increasing the diuretic, empower patients to use diuretics themselves. That's where skills come in. That's where an ideal weight comes in. So we actually empower patients to look after themselves. And we may need to look at a different diuretic, additional diuretic. We may need to look at reduction in the beta blocker for a wee while.
What would your additional diuretic be there, Gerry?
I'd just use a simple thiazide, to be honest, and bendofluozide's the one that I'm used to using.
You haven't joined the clothalidone club
You like
yet.
clothalidone? Do you use clothalidone in this setting?
Well, in the ALLHAT study, it was significantly better for heart failure than
Yeah.
doxazosin. I think it's actually...
Yeah. Bruce, I must admit, I'm not familiar with it. I need to get more familiar with it, and I think I will.
I'll send you an invite to the fan club.
ARN therapy, so ARN's topical in the heart failure world, and the trials that we've got to date suggest that ARN, so 2AA means not a lot of large randomized trials to tell us what to do. There is no mortality benefit. There is no reduction in hospitalizations. It makes people probably feel better, and that's what the guidelines say. There's a big trial going on that New Zealand's involved in. It's powered to look at hospitalizations and mortality that will hopefully answer this definitively for us about whether IV ARN is a benefit. So you guys are involved in it? Yeah, you involved in it? Yeah. So we're involved as well. So so watch this space, probably 2-3 years before we have anything out of that trial. Oral ARN doesn't do any good. Okay, so it does not reduce heart failure hospitalizations or make people with heart failure feel better. I mentioned SGLT2 inhibitors earlier. These are an important class of medications for people with type 2 diabetes, and this is real-world practice with a registry CVD rail, and it reduces all-cause mortality significantly. Hospitalized.
It's not funded, Gerry.
It's not funded.
Yep, they're not funded yet. There's lots of stuff going on, hopefully. But heart failure hospitalizations, this presented at the European meeting in August, and again, standing applause in the auditorium when John McMurray presented this trial. This, I believe, is going to be a game changer in heart failure reduced ejection fraction as well. So we know these drugs are good for people with type 2 diabetes. We've now got a trial in heart failure in a non-diabetic population showing they reduce events in people with heart failure reduced ejection fraction, reduction in cardiovascular deaths and heart failure events with I think it's dapagliflozin. So it's DAPA. So again, this probably there will be, in the next 2 years, there will be at least another 10 trials report on this class of medications in various cardiac-related conditions.
Is it true there's some sort of Parliament website lobbying thing going on that you can
Says
go
we
on?
can go and sign up to, apparently.
Yeah.
For diabetes?
Yeah.
Yeah. So I know there was a meeting about 3 weeks ago that Rinky Murphy, she's a diabetologist in Auckland. She got a few people together, PHARMAC attended, around trying to get some consensus around and some sense around access to these class of agents for diabetes. Forget this trial, this is a wee way away before we look at this population. The proposed criteria are nonsensical. So PHARMAC, the diabetic subcommittee of PTAC, are proposing a HbA1c restriction. All international guidelines now would say if you've got type 2 diabetes and you've got high cardiovascular risk, you should be on an SGLT2 inhibitor as your first choice agent. So that's what we are recommending. So we're saying we do not accept restricted access. You know, our role, I believe, firmly is to champion for best care, not to actually endorse restricted access. I know it's complex, Bruce, but I think on behalf of our patients, we do not want restricted access to these medications. I think this is an interesting trial that I saw recently in the European Heart Journal on the benefits of bariatric surgery. We do some bariatric surgery in the Midland region. We probably do not do enough bariatric surgery in the Midland region. And what they looked at is the risk of heart failure in patients undergoing bariatric surgery versus usual care over many, many years in Sweden. And they showed that the risk of heart failure declined in patients who had the greatest weight loss, but also maintained the greatest weight loss. So bariatric surgery is fine, but you have to maintain the weight loss. If you maintain the weight loss, there was benefit, sustained benefit. So aortic stenosis, you all know how important aortic stenosis is. You all know that our ability to treat aortic stenosis is changing. The way we treat aortic stenosis is changing. We now have a couple of trials presented this year in lower risk populations that show similar, if not better outcomes. Partners showed better outcomes than surgical TAVI in a low risk surgical population. This trial showed a similar outcome. And I would predict that this will become the standard of care for the treatment of aortic stenosis within the next 5 to 10 years. So I think we're going to see a huge change in how we treat aortic stenosis, an important cause of heart failure in our community in the next 5 to 10 years. Implications, lots of levels for us, including workforce planning in New Zealand. I just want to talk a little bit about, I won't go through the case, but I want to talk about heart failure preserved systolic function. It's a common reason for heart failure admissions in New Zealand, and this is data that we've published in conjunction with Singapore, where in our population, almost half of women admitted with heart failure have got heart failure preserved ejection fraction. So you need an echo to diagnose this, don't you? You've got an echo, shows LVEF's above a certain level. The patient's got symptoms of heart failure confirmed by a natriuretic peptide assay, okay, or a chest X-ray showing pulmonary edema. The outcome is not as bad as heart failure reduced ejection fraction, but if you compare it to a normal population, it is not the same as if you don't have heart failure. Okay, so there's a gradation of outcomes, and this is death and heart failure admissions, as shown here in Caroline's slide.
What's the MR, the middle one, MRE?
So heart failure mid-range ejection fraction.
Mid-range.
So we like to complicate things.
The rule of threes.
Don't ask me why.
The rule of threes, yeah.
Don't ask me why. So if we look at similarities to heart failure reduced ejection fraction with heart failure preserved ejection fraction, diabetes, smoking, lipids, weight, atrial fibrillation, all similar common bedfellows in both conditions. Heart failure preserved ejection fraction, more likely to be older, more likely to be women, less ischemic heart disease, more hypertensive, smaller, thicker ventricles. Okay? Difficult condition to treat. We do not know what works. We have no good treatments that influence outcomes in people with heart failure preserved ejection fraction. We thought Entresto would be the answer, and the Entresto Paragon trial presented at the European meeting recently as well. It did not receive applause at all. It missed its primary endpoint, marginally missed its primary endpoint. I think the issue here was that it went head-to-head, it went against valsartan 160 milligrams BD as opposed to placebo. The reason it did that was because treating blood pressure with an ACE inhibitor or an ARB is common in this group of patients. So they thought it would be quite difficult to go head-to-head with a placebo. But at the moment, the promise of this drug in the heart failure reduced preserved ejection fraction population has not been fulfilled. Lots of subgroup stuff from this trial suggests that people felt better, quality of life improved, effort tolerance improved. So I don't think we've heard the end of the story with this particular salbutamol valsartan in this population. Lots of interest in the SGLT2 inhibitors in this population as well. So again, there's lots of trials going on with the SGLT2 inhibitors in people with heart failure preserved ejection fraction. So I'm going to stop there. Speaking about heart failure, we've had a bit of a whistle-stop tour through things again here, but hopefully I've given you a flavor of where we are, how we should be treating people with certainly evidence-based care of heart failure reduced ejection fraction. The complexity of heart failure preserved ejection fraction remains, with no right or wrong ways of doing it at the moment, other than treating blood pressure well.
And statins, and because that's I think one that gets missed a bit in heart failure. We're chasing all the other drugs, and we tend to forget the
Yeah.
the
And again, getting back to that slide we showed, trying to prevent things progressing that may adversely impact on LV function, such as that chap we spoke about earlier. 20 milligrams of.
So other than diuretics, nothing for preserved ejection fraction.
So what do? I tend to treat their blood pressure well. If they've got LVH, a lot of them will have LVH. I'd make sure I'd aim for a blood pressure probably 120/80 or better in that population. No evidence base around that at all. I'd exclude ischemia. That's a really important thing to exclude as a cause of that patient's symptoms. And I'd also look for atrial fibrillation, which we did in this lady, and she had atrial fibrillation. So again, other things in a ventricle that's a little bit stiff may lead to decompensation. So I think that's the complex condition.